Toss endless online searching to the curb. Let us edit out the noise and bring you medicine without misinformation. Welcome to the MedEdit Podcast. Hello, and welcome back to the MedEdit Podcast. I'm your host, Dr. Jessica Gray, accompanied as always by my amazing co-host, Dr. Cari Sorrell.
Thank you very much for that warm welcome. This episode, we are diving deep on a topic all women and even men would benefit from. We are talking about the health of your bones.
Osteoporosis is common in women, and one half of women will experience an osteoporotic fracture in their lifetime. We are joined in studio today with a familiar face, Dr. Taylor Warmoth, our favorite rheumatology expert who is going to help us truly understand osteoporosis and osteopenia. And then stay tuned for our Hollywood Hype segment that has to do with Kim Kardashian and the Met Gala. Only the MedEdit Podcast can bring you both those topics in an educational manner.
Absolutely. This is going to be a fantastic episode with a lot of great information. So feel free to pause, rewind, and take notes. Let's get started.
Welcome back to the podcast, Dr. Taylor Warmoth.
Hi, guys. I'm so happy to be here. I'm shocked you invited me back after I talked about some of the things I did last time, but I'm glad to be back on your podcast today.
For our listeners who may not have caught Dr. Warmoth on episode 3, she is a board-certified rheumatologist with a wealth of knowledge about all things autoimmune and bone health related. She's in private practice at Arthritis and Osteoporosis Associates in Lubbock, Texas. She's also an adjunct faculty professor for the Texas Tech Health Sciences Center School of Medicine. Thank you again for joining us.
Of course, let's talk some shop about some bone health.
Awesome. And I will say, Taylor, your last episode was one of our most popular, but I don't know if it was because of you or my anal fissure part. We don't know. Who knows?
Itchy buttholes are always going to get attention.
Yeah,
I'll tell you
right?
that much.
Yeah, I just did a lead in there for you. So Dr. Warmoth, let's get started with the basics. What is osteoporosis?
So osteoporosis is one of two forms of bone thinning, the other being osteopenia, which is less severe. Osteo means bone, porosis means porous. And so basically what that means is the scaffolding that builds our bones starts to get thin over time, making them more prone to fractures or breaks, broken bones.
Okay. And how is osteoporosis diagnosed?
Osteoporosis is diagnosed one of three ways. The way that I think most people would know about is what we call the DEXA scan. DEXA stands for, it's a beam of radiation, actually less than a single chest x-ray, that is used to look at the bones, usually of your back or your hips. Those are the most commonly fractured bones due to osteoporosis. Obviously, lots of women end up having hip replacements in their life, or they may have a back fracture requiring surgical fixation. So we can also sometimes look at the forearm. And so if we can compare your bone density to other women your age, we can see if your bone density is much worse than other people would compare. So that's one way. Another way is if you sustain something called a fragility fracture. And that is if you break a bone basically in a way that you shouldn't have. So if you have a simple fall, you trip on a stair and you manage to break your wrist, or if you miss a chair and you break a hip, those are what we would call fragility fractures. And so if you're breaking bones too easily, that's usually a way that we can diagnose osteoporosis. And then the third way is something called a FRAX score. And a FRAX is very unique, but what this does is it takes your individual risk factors and uses those to calculate your 10% or your risk of fracture over the next 10 years. So they look at two types of fractures, what they call a major fracture, which is going to be a neck, a shoulder, a wrist, a hip fracture, a back fracture. And then they look at just the risk of hip fracture. And if your percentage risk is too high, we will call you osteoporosis.
And you mentioned risk factors. How do I know if I'm at risk for osteoporosis?
Absolutely. So number one, as we lose estrogen, our bodies tend to start to lose calcium. We become at more risk of osteoporosis. So once we hit that nice round of menopause, the development of osteoporosis is far more likely. But a couple of other things make people more prone to osteoporosis. Certain family histories, things like having a parent that broke a hip fracture, maybe having early menopause run in your family or experiencing it yourself can increase your risk. People who are somewhat inactive and don't do a lot of weight-bearing activities, women who are very thin, particularly weighing less than like 130 or 127 pounds technically, women who drink more than 2 beverages of either alcohol or coffee a day. Those both put you at risk. People who smoke, and then certain medical diagnoses. So people who have asthma or thyroid disease and have needed a lot of steroids throughout their life, chronic steroid use will put you at pretty significant risk of osteoporosis as well.
Okay, good to know. So if you have osteoporosis and you talked about fractures, you can do some like exercises to improve strength and balance, or how do I change those risks?
Absolutely. So the number one thing we need to do is try, and in today's day and world, it's hard, but trying to live a healthy lifestyle, right? Decreasing our alcohol and caffeine intake. And I'm going to say more with caffeine, but I struggle with both. Don't smoke if you smoke, and then getting good amounts of calcium and vitamin D. Calcium, honestly, we can supplement both of those things with vitamin supplementation, but calcium is best if it's gotten organically, meaning through your diet. So milk, cheese, almonds, tofu, fruit juices with calcium added, yogurt, all fantastic sources of calcium that can help you get that strong, good bone density. And then supplementing with vitamin D, or getting, Dr. Sturgeon, getting 10 minutes of sun exposure every day, wearing an SPF of 8 or less, but 10 minutes of sun exposure with some good sun exposed areas, wearing a tank top and shorts, can really help you maintain your vitamin D levels. And then we also need to look at what causes fractures. So falls are like one of the number one causes of fractures. So making sure that you work on your general strengthening and your balance can really help prevent future fractures, which is the entire goal here, right? With my patients, what I have seen, most falls happen over rugs, right? We want cute houses. We see all these fun places on Instagram and they have the cute little rug from Anthropologie. But if it rolls up and you catch your foot on it, you're going to go down 9 times out of 10. And so if you want rugs in your home, perfectly fine, but you need to make sure they're taped down. And we also recommend getting rid of all rugs in the bath. You just don't need rugs in the bathroom. Keep one for your shower, but otherwise that fluffy white rug that you stand on while you brush your teeth really isn't worth the risk of a broken hip. So that's kind of what we do to try and prevent the development of either osteoporosis or fractures.
So when we're talking about that vitamin D, what's the appropriate dosing of vitamin D and calcium? Should people have concerns about cardiac health with calcium supplementation?
This is a hot topic in the very boring world of osteoporosis studies, but I think it's interesting. So vitamin D, there has been some toss up depending on age. And really what we should target for, more than a number that you take, is a number that stays within our body. So everyone actually converts vitamin D a little bit differently, but vitamin D is very important because it helps us absorb calcium and kind of stabilize those bones. So typically the recommendation for vitamin D through the American College of Endocrinology is going to be somewhere between 1,000 and 2,000 international units of vitamin D daily. If you are under the age of 50 or 65, 1,000 units is usually good enough. If you're over the age of 50 or 65, depending on family history, usually they recommend 2,000. People should see their doctor. We should be getting our vitamin D level checked every couple of years to see, am I maintaining this level? Or, if you've lived up north, you may need more vitamin D supplementation. And so the actual dosage really is going to vary person to person. Calcium, we typically recommend 12,000 milligrams of calcium per day. Now, what's come out of some of these new cardiac tests that are being done is what we call the calcium artery scoring, or where they look at the calcium buildup in someone's heart vessels and see if they're at increased risk for heart attack. So there was a big study done about, is taking too much supplemental calcium putting you at increased risk of heart disease? And the answer was maybe, maybe not. What seemed to be safest was natural sources of calcium. People who got their calcium requirements through milk, yogurt, fruit juice, did not seem to have any clinically increased risk of heart disease. Those who were having to take a lot of supplementation to get their 12,000 milligrams may have had a slightly increased score. So I always give my patients a nutritional sheet before they leave with how many milligrams are in each particular food item so they can try and meet that 1,200 milligrams a day more organically and with more natural foods.
How is osteoporosis actually treated?
So osteoporosis is treated depending on how severe it actually is. So the way bone is lost, we have two types of cells involved in bone turnover. Bones are constantly turning over so that the calcium doesn't get too brittle and break. And so there's a cell that comes in and chews up old bone. And then there's a new cell that comes in and lays down new bone. And so, chews up old bone, and then a different cell lays down new bone. So we can either stop the chewers from chewing up the bone, or we can boost up the builders. Patients who are more severe get the medicines that help boost up the builders. And that's because those medicines are a little more aggressive and far more expensive. And so insurance companies don't just let us give them out all the time. But two that are on the market that are probably widely known of is Tymlos and its cousin Forteo. Both of these medicines are taken by injection into the belly, and you have to do that every day for 2 years. But those medicines have been shown to reduce fractures by up to 80-something%. I think 87% was the last study I saw. And so those medicines are fantastic, but boy, are they a commitment. And so if your bone density is not that bad, there are some other medications on the market that have been used for decades called bisphosphonates. These medicines can be taken either as a pill or as an IV. The pill can be taken either once a week or once a month. One was featured, if you ever watched Grace and Frankie, they talk about Boniva on Grace and Frankie, except every single episode they called it Bovina, which drove me insane. I almost had to stop watching. But that's a pill that's taken once a month. And then there's a infusion version called Reclass that's given once a year. Very easy. You're in and out of the clinic in about an hour, but it can cause some bone achiness. Some of my patients do tell me these medicines make them hurt a little bit. And what's really happening here is you're experiencing growing pains. And we stop having growing pains at age 12? So it's just very unusual to experience growing pains again as an adult. And that's what usually happens. Those seem to be very mild symptoms for most people that ease very quickly after treatment is started. Two other options that are out there, one that the OB-GYNs love in particular is called Evista. And this is a once-a-day pill that helps a lot with bone density. It also reduces your risk of breast cancer. So if you have a strong family history of breast cancer, this is a fantastic option for you. And then there's good old Prolia. Prolia is my tried and true. She is my best friend in my clinic. It is a shot once every 6 months that you can do for the rest of your life. Most of these medicines we do anywhere from 2 to 5 years, and then you take a break, and then we restart them, and then you take a break, and then we restart them. But Prolia is lifelong. So I do try and avoid starting that until you're at least over 65, because otherwise 30 years on a medicine is a pretty big commitment. So the younger you are, the more I try and avoid Prolia. But there are a lot of really good options and very personalizable options out there for treating bone density issues.
I love it. That is so helpful. Can you tell just a little bit any contraindications to any of those medications? Like, who would not be a good person to use that for?
Fantastic question. So these meds come with side effects. Every medicine that we ever give patients comes with potential side effects. In particular, the bisphosphonates, your Fosamax, your Boniva or Bovina, and your infusions can come with a risk of something called osteonecrosis of the jaw, which is actual death of the jawbone. This sucks. It is incredibly rare. We are talking a 0.01% to 0.15% chance. But it can happen in people whose jawbone gets exposed to air. So if you were about to have a bunch of dental work done, extractions or implants, if you have poor dental hygiene, if you have had issues with jawbone in the past, those are not good options for you. Now, some patients are able to get their dental work done get their dentures placed, get their implants done. And once they've recovered, they can safely undergo treatment. But you need to talk to your dentist first before starting on any kind of treatment for bone density.
Now, somebody who doesn't have any dental issues and they're just going for normal routine cleanings and things like that, do they have to be extremely concerned about that potential side effect?
It's a much lower likelihood with good routine dental hygiene. And if you go to the dentist while you're on those meds and God forbid you need a cavity filled, totally fine. Just make sure you're in communication with your dentist so they know you're on those medications so they can take any additional precautions if needed.
Wonderful. Well, what about alternative or homeopathic remedies?
Okay. So I do have, because the internet, especially with my osteoporosis patients, is a scary place, man. Like you said at the beginning of the episode, 50% of women in their life break a bone due to osteoporosis. That is a huge market. And if there are 7 billion people on this earth, let's say half of them are women and half of them are going to break a bone. And then let's lower the number just for fun. 1 billion women have this problem. If I can sell a product to some woman because I can make a fancy looking website, there is a lot of money to be made. So I will say there is a lot of misinformation, more than any of my other diagnoses online, about osteoporosis treatments. I've had people come to me asking about flax seeds and green tea extract and prunes, and there is no evidence to support that these things have any benefit. Soy flavones may slightly decrease the risk, but more than anything, getting good weight-bearing exercise, taking a good vitamin D, and consuming good amounts of calcium are the best ways you can treat this more naturally. Other than that, I'm not a huge fan of the all-natural things here just because they have not been scientifically proven, and this is a very vulnerable population to be taken advantage of.
I always say it's predatory behavior in medicine. We have a lot of things that are very predatory. It's somebody selling you something.
Yes.
A lot of that has to do with even like hormonal treatments. They'll say, do this because it's more natural. And somebody's just going to stick their hand out and ask for cash too, while they're also giving you these all natural treatments or their proprietary blend that they made for you. So just another disease process that, especially in women, right? Once again, in women, that is being taken advantage of.
Yes. Absolutely. I think part of that is women are very eager to we take care of everybody else in the world. Why shouldn't we take care of ourselves? And so when we finally get around to taking care of ourselves, somebody thinks, oh, I can sell her something. Whether it's a story or an opinion or a product, they're going to try and sell us something.
Absolutely.
This is such helpful information. And now let's move on to our second segment, or our Hollywood Hype, where we talk Kim K.
All right. I'm way excited about this one.
You know, I just love the Hollywood Hype segments. And today we're talking, yes, Kim Kardashian. So the Met Gala was a few months ago. And as usual, Kim Kardashian was in attendance looking fabulous. But she recently was interviewed and discussed how a psoriasis flare-up on her face almost ruined her night. She has been very open about discussing her struggle with psoriasis. And she mentions that this flare-up wasn't her usual one spot, but instead covered her whole face. She also mentions that she suffers from psoriatic arthritis in this interview. This is an interesting topic that our favorite rheumatology expert, Dr. Warmoth, here can actually help us elaborate on. So, Dr. Warmoth, can you give us an overview of psoriatic arthritis? Who gets it? How is it diagnosed? Break this down for us.
Absolutely. I love this topic. And so psoriatic arthritis typically develops in those who have psoriasis, which is an autoimmune disease in which the skin produces way too many cells. They get the flaky, itchy rash that can occur really anywhere. I think people always think it only occurs on the elbows. It goes everywhere. But about 1/3 of people who have psoriasis will develop psoriatic arthritis. What's interesting is that currently only about 25% of people who have psoriasis are actually diagnosed. That suggests that psoriatic arthritis is underdiagnosed. And it's possible because many treatments for psoriasis also treat psoriatic arthritis that patients just never even know they have the disease. But certain features of psoriasis make you more prone to actually developing psoriatic arthritis. One, and I like this word because it's big and fancy, is something called enthesitis. And enthesitis is inflammation where tendon inserts into bone. Most of the time, it's going to be in the inside or outside of your elbow, or at the very bottom or very back of your heel, either plantar fasciitis or some Achilles enthesitis. This is different than tendonitis, which is an overuse or injury related problem. Another thing that can make you very prone to psoriatic arthritis is something called pitting of the nails, which is when someone looks like they've almost taken a needle and driven little divots into their fingernails. And when you have more than 10 pits in a couple of fingernails or toenails, that increases the likelihood as well. There's something called onycholysis, where the nails get very thick. That increases your likelihood. But the biggest thing that seems to increase the risk of psoriatic arthritis is involvement of the scalp. So if you start to get psoriasis on the back of your head and your hair, behind your ears, that increases your likelihood of developing psoriatic arthritis to nearly 80%. So the odds of developing psoriatic arthritis with those features is much higher.
That is so good to know. I think everybody's gonna be staring at their fingernails looking for pits now too, right? Okay, so how do you treat this?
Absolutely. So a lot of options with treating psoriatic arthritis. I kind of morbidly joke with my patients that it's one of my favorite conditions to treat because there are so many options. For psoriasis itself, there are topical agents. You can use, steroid creams, those kinds of things. But then there are all sorts of medications available at my disposal, which are either immunomodulators, meaning they modify how the immune system functions, or immunosuppressants, meaning they actually do suppress that abnormal immune system function. I think the ones most people are going to know about from the commercials would be Humira or Rinvoq. I think everybody's ziplining in that commercial. We also see it with things like Taltz, Skyrizi. If there's a catchy jingle for it, odds are it treats psoriatic arthritis. I also joke with my patients, though, the more commercials you see for a drug, the more expensive it is. So there are some very old drugs out there that are cheap, quick, and dirty. And I do mean dirty, but they do treat the arthritis well. And those are going to be medications like methotrexate, which is actually an old chemotherapy. And I'm sure me even using that word will trigger some of your listeners because some people love methotrexate because it fixes their issues, and some people hate it because it comes with a whole multitude of side effects, including hair loss, canker sores, stomach upset, fatigue. And so you really, again, have to customize your treatment. What Kim Kardashian says that she did right before her Met Gala was a hefty dose of steroids, which in a pinch is a nice fix, but that is not something you could safely continue long term because of the many side effects associated with steroid usage.
So how much does stress, or with Kim Kardashian, the carnivore diet, which I'm sure that Dr. Sorrell Hill can comment on that as a GI doctor, play in the role of these flare-ups?
Stress and diet have massive, massive implications in the activation of or flaring of inflammatory diseases. So, in fact, when my patients come to me and they say, I've had a flare, before I even start thinking about changing their medicines, I say, okay, let's talk. What's been going on recently? And almost always they'll say, oh, we're having to move my mother into assisted living, or, oh, my kid got in trouble at school, or I'm having difficulties at work. There's so many times a stressor underlying this. Stress plays makes a huge impact in our cortisol levels. Cortisol is a massive implicator or player in inflammation. And so stress and diet have huge impacts on inflammatory disease. Diet's a little unique to the individual. I have some patients on carnivore diets who love it. They say they feel so much better. Not my favorite diet because of the risks of cardiovascular disease that come with it, colon cancer, those kinds of things. But some people need to be gluten-free. Some need to be dairy-free. Some need to be, wheat-free or red dye number 40 free. And so everybody just kind of has to find their own individual diet. I tend to like the Mediterranean diet best. And what I recommend to people while you're trying to figure this out is keep a log. Start writing just a little diary. Today, I had a thing of yogurt at breakfast. I had a grilled cheese sandwich for lunch, and I had pasta at dinner. Oh, man, that sounds like a good day, doesn't it?
It does.
And then the next day, come back and a check mark if you feel good and an X if you don't feel good, and start to look for trends. my gosh, every time I eat cheese, I don't feel well. And see, is there some kind of connection there for each individual and food?
Yeah, absolutely. And I think the conversations you have with those patients are pretty much the same I have with my inflammatory bowel disease patients. A lot of the same stressors, a lot of the same diet modification needs, medications. It's basically very similar. And you're right. It's stress and how we manage it, diet and what we're changing. And I'm sure people are tired of hearing about us saying diet and lifestyle, but it's true.
Well, Dr. Gray, what's your saying always? An ounce of prevention is worth a pound of cure.
I wish that I could claim that was my saying that I made up, but yes, Benjamin Franklin came up with that, but it's 1000% true, and I will quote him all day long. Yes, it's so true, though. If we can prevent
that's the one
something,
I always hear come from you.
Yes, if we can prevent something, it's so much better than trying to treat it later and play catch up as well. So
Absolutely.
This has just been fantastic information today. Thank you, Dr. Warmoth. We have learned so much about healthy bones and itchy skin.
Hey, better than itchy buttholes, which is what you guys had me talking about.
You know what?
Last time.
Yes, and that was a very popular episode. So if you did not,
why do I always get the itchy conversations?
If you missed out on Dr. Warmoth's itchy episode 3, make sure you check out that one as well.
Listeners, during the discussion in this podcast, Dr. Taylor Warmoth mentioned 2 different dosage amounts of calcium as a daily recommendation. The correct dosage is 1,200 milligrams of calcium per day. Our apologies for this error. Please remember to always consult with your healthcare provider before making any changes to your medication or supplement dosage. Thank you.
Thank you all for listening. Please like, subscribe, and share the episode. If you're claiming your CME credit, be sure to check out the show notes for instructions. Let us know what other topics you're interested in through our Instagram, and stay tuned for the next episode.